Good morning and welcome to Connects Online 2021. It's a real pleasure to welcome everybody to today's event. As is common with events of this nature now, it's traditional to say that we are obviously experiencing unprecedented times. And Connects would usually be a live event. For the past few years, we've been hosted by Swansea University. And only last night, I was looking through some of the photographs on Twitter of previous Connects events to see the crowded exhibition space in the Great Hall, and the presentations going on all over the building, and the interactions and the meetings, and it was a real shame to be thinking that we wouldn't be having that amount of contact and engagement face to face today and this week. But nevertheless, our online format allows us some of the benefits that face-to-face contact doesn't have. We are going to be engaging this week with an awful lot more people. We're going to be welcoming people not only from all over Wales, but from across the UK and internationally. So welcome to all of our guests and visitors. So it does have some benefits. It has some major benefits. One of the other benefits is that we are recording. We're recording today's session. We'll be recording all of the sessions that you hear throughout this week. And as a result, we're able to share them. We're able to share them on YouTube and through social media channels. And by doing that, we're able to make the most of the presentations, of the quality of the presentations, and the fabulous speakers that we've got presenting throughout the week. So I'm really looking forward to both hearing speakers live and sharing those presentations wider and further. So yes, we are recording, and so you can consider yourself warned. If any of the presenters, if any of the speakers don't want their presentations to be shared beyond today's event, then you only have to tell Isabel, and we will of course honour that request. Another note to speakers is, if you would please keep to time. We have got quite a packed schedule. For those of you who have seen our digital programme, then you know that we've got a lot of really great presentations and good speakers to get through today. So we are going to be asking you to try and keep to time, and that way we should be able to fit in some questions and a bit of Q&A as well as the presentations. But it'll also mean that our presenters, even those coming towards the end of the sessions, will have their fair share in the limelight. A note to those of you who are here as observers and delegates, please use the chat, please use the Q&A. It does feel a little odd when you are presenting to dozens of people, but you're actually in a back bedroom or in a home office and you're staring at a wall or staring at a screen. So interaction really does help. So please use the chat, not only for questions to speakers. You are more than welcome to introduce yourself, just to say that you're here, just to say what your products are, what you do, what your services are, which part of the NHS you're from. This is a collaboration conference, it says so in the title. And really our aim is to bring together the NHS and industry and academia from across Wales and beyond. So if you can use the chat to introduce yourselves, then we'll get a lively session going alongside the speaker program. If you are in one of our more interactive sessions, then you can raise your hand to ask a question, and Isabel and Sam throughout the week will be manning the Q&A, and they will either sort out the questions and make sure they get asked, or we will promote people to speaker so that you can ask the questions yourselves. For those speakers who are on the programme, you will be promoted to speaker as and when you're required to provide your slot. So if you're looking at the if you're looking at your dashboard now and you're not sure whether you're going to be able to provide your presentation, please don't worry. Isabel is in the background. She's watching everything, and she will be promoting you to speaker. We've provided a phone number, and if you do have any technical issues, please do let us know. On the subject of technical issues, then this is unusual for all of us, and MediWales has provided a programme of presentations, conferences and awards throughout the year. We are quite accustomed now to presenting in this format and digitally, but it's digital and everybody's presenting from different parts of Wales, and home Wi-Fi can go down and presentation slides cannot work. So please be patient with us on this occasion. But also, presenters, be prepared to maybe be bumped up the programme a little. If somebody can't get their presentation to work, we might do a little bit of reordering. So just be aware, be alert, and if it happens, then everybody will be ready. But we'll make sure that everybody gets their speaking slot, and we'll make sure that things run as smoothly as possible. So it is my pleasure now. I've done the housekeeping, and so now it is my pleasure to introduce Dr. Andrew Goodall, who's Chief Executive of the NHS in Wales, who for a number of years, since our conference started, Andrew's been a great supporter, and it was actually with him in his office that we conceived the idea of the Connects as an NHS collaboration conference, and it was Andrew's understanding of the need to collaborate that really prompted us to deliver the event. So without further ado, I would like to present Dr. Andrew Goodall for his welcome presentation.
Croeso pawb, welcome everybody to this year's MediWales Connects conference. This is an all-Wales collaborative conference for the health and care communities, health boards, trusts, as well as innovators and leaders from industry and academia. When asked to provide an opening address by MediWales, I was delighted again to be offered the opportunity to play a part, as I have done since the inaugural conference event held 6 years ago. And although we were unable to meet in person as previously, I hope that you're still going to take advantage of the opportunity to network, make new introductions and share your experiences in this ever more familiar digital arena. As always, I'm encouraged and inspired by the impactful stories from across Wales that are shared at this event, and how individuals, organisations and communities are able to demonstrate collaboration at its very best to tackle ever more challenging issues in what is a very dynamic landscape at this time. COVID-19 has reminded us again of the importance of collaboration and cooperation, and how we are able to achieve greater impact as a result of aligning our focus, priorities, activities, and through pooling our collective knowledge to respond at pace to new challenges. The pandemic has been and continues to be a true test of our health and care system, and it's evident to me that through the foundations laid by A Healthier Wales, which is our long-term strategy for integrated health and care, we've created an environment in which our partners and workforce have actively embraced and delivered transformation and innovation at pace. Often, I have to say, delivering in very difficult circumstances. COVID-19 has created a unique context for rapid innovation and made delivering high-quality integrated health and care services more important than ever before. For example, at the early stage of the pandemic, less was known about COVID-19, including how to effectively sanitize environments which have been exposed to the virus. To decontaminate any workstation takes time. You can imagine the additional effort and time to decontaminate an ambulance that has transported a suspected or confirmed COVID-19 patient. This was taking precious resource away from the frontline effort while the vehicle was made safe for the next patient. To help find a solution, the Welsh Ambulance Service worked in partnership with the Small Business Research Initiative Centre of Excellence, hosted by Betsi Cadwaladr University Health Board. The SBRI Centre was able to issue a special rapid challenge to the business community of Wales to come up with an innovative method of faster sanitisation of our ambulances. Now, the really impressive bit, typically an SBRI challenge and bid can take around 12 to 18 months to complete, but the rapid process applied to this challenge slimmed that time down to an incredible 6 weeks. This fast-track bid process received more than 200 applications in a week, the most promising of which were invited to the Ministry of Defence's Science and Technology Laboratory at Porton Down for further testing and evaluation. As a result, several solutions were further trialled by the Trust, which has since been able to move forward to implement a final solution. This was the first rapid SBRI challenge project in the UK, and I think showcases Wales' aptitude for innovation and partnership working. It also served to highlight how collaborative effort can move the most ambitious project forward and at pace to a successful outcome in the most difficult of times. The past year has been incredibly challenging for all of us, professionally and personally, and part of the challenge as we move forward is to harness ways of learning to capture best practice and learn the lessons of projects such as this. I'm aware of the breadth of collaborative work ongoing to capture new ways of working and the innovative practices adopted in response to the COVID-19 pandemic. An NHS innovation study was undertaken to capture and better understand what novel and innovative practices emerged in responding to the pandemic, demonstrating successful themes and case studies that can help to inform, enable, scale and sustain innovative and transformative ways of working across NHS Wales health boards and organisations. A formal report has been produced by Swansea University in partnership with an RM Bevan University Health Board, Health Education Improvement Wales and Welsh Government, and is being published during March. A similar activity is also being undertaken for social care through our Research Innovation Improvement Coordination Hubs, and this evidence will be critical in shaping our next steps as we start to plan for recovery. I look forward with interest to not just reflecting on the findings from both, but using them to implement a range of different changes and transformation across Wales. So I hope that today you seize the opportunity to share your experiences, best practice and learning with each other. I hope that you too are as inspired as I have been in reflecting on this year's stories, and that it provides you with the motivation to continue to innovate, collaborate and make a difference to the health and well-being for all. I thank you all for your hard work over the past year, and I wish you a very enjoyable and inspiring day. Diolch am wrando. Thank you very much for listening.
So thank you very much, Andrew. Thank you for that for that talk that really does. He brought together in very few minutes what was actually a huge amount of activity and unprecedented times for the NHS and in collaboration with industry, and some of the comments that Andrew made there were reflecting on projects that have involved collaboration and coordination across Welsh Government, across academia, and as we all know, our NHS colleagues who really have done us proud over the last year. So thank you very much to Andrew for that. I'm really happy now to be able to introduce our first speaker, Dr. Orod Osanlu, who's Betsy Cadwallader University Health Board Principal Investigator for the Vaccine Trials Wales and consultant in clinical pharmacology and therapeutics. So Dr. Orod, if you are on screen, if you can turn your camera on now, then I will hand the floor to you, sir.
Good morning. Can you hear me?
And we don't have sound yet. Are you muted?
You got me now? Can you hear me? Hello?
Oh, so
how's that now?
The rest of the team can hear you, so I will. I'll leave the stage and leave it to you. Thank you.
Okay, great. Well, if there are any problems, let me know. Thank you very much for the introduction and inviting me today. As a bit of a disclaimer, it's half term and I'm on annual leave, so I'm also in my office from home, and I haven't got the best Wi-Fi, but hopefully it will hold out. And in case you hear any kids screaming, that's my 3- and 5-year-old downstairs. They're with their mum, so I've not left them by themselves, but I've heard them screaming quite a while for the past few minutes, so you might hear some odd noises. Right, so let me share this presentation. Okay. So good morning. So I'm a consultant in clinical pharmacology and therapeutics, and today I'm going to be talking about delivering a vaccine trial in North Wales in challenging circumstances. So I have a special interest in clinical trials, and as my introduction, I'm the All Wales Deputy Principal Investigator for COVID-19 vaccine trials. But today I'm going to be speaking in my capacity as a Principal Investigator for the Novavax trial in North Wales. And I do like a good photo to start off a presentation, so I couldn't resist including here aqueduct that we have in Wrexham, a UNESCO World Heritage Site and the longest aqueduct in Great Britain and the highest in the world. So the COVID-19 pandemic has brought society to a standstill. We have more than 125,000 official deaths in the UK already, and unfortunately the final death toll is likely to be much higher. Society has been brought to a standstill, people have lost their jobs, mental health has suffered, the economy is struggling. It's clear how much of a toll COVID-19 has had on us all. But with adversity comes opportunity. There have also been success stories. We have seen a flurry of vaccine trials throughout the world. Some have had a head start due to SARS-CoV-1 and MERS research, but in less than a year, we've had multiple vaccines developed and licensed, which would usually take 5 to 10 years. The scientific community has really come together as a whole, as has society, to tackle this problem. And here we see a depiction of Edward Jenner and the famous smallpox vaccine story, originating from first identifying cowpox. Of course, we know that smallpox has now been eradicated, and as success stories go, to me, this is the most inspirational, that we can and we will defeat COVID-19. So at a Health and Care Research Wales level, excuse me, there has been a drive to deliver research throughout the whole of Wales. North Wales may not currently have the facilities present in the south to deliver clinical trials. However, Wrexham was a natural choice for the Novavax vaccine trial. Wrexham has more than 120,000 people living within 5 miles of the town centre and more than 500,000 living within 30 miles. The North Wales Clinical Research Centre is where we're delivering the trial, as you can see here on a nice sunny day. It's very close to the A483. It has frequent bus services, is very close to 2 train stations and also Wrexham Town Centre. And it's also just a stone's throw from Wrexham Mile Hospital. So setting this up with, we only had 10 days notice, and I'm used to having months and months to set trials up. So it really was a huge challenge. However, we've had tremendous support from Public Health Wales, Health and Care Research Wales, locally in Wrexham, and the BCUHB executive team. Everybody was prepared to go the extra mile to try and get this done. This is our socially distanced picture on day one with me doing a selfie at the front. And in the background, you can see doctors, nurses, trial coordinators, phlebotomists, lab staff, the data team, and many other team members. We had doctors from all over Wales and even coming from England as far away as Cornwall and Newcastle to help deliver the trial. We had nursing staff commuting 1.5 hours each way from the other side of Bangor to Wrexham to help deliver the trial. It really was a huge team effort. And then in the background, you can see the North Wales Clinical Research Facility. Don't let the nice weather fool you. There were gale force winds that day. And within an hour of starting, that gazebo you can see had blown away. So we all had to multitask and come up with innovative solutions to fix the gazebo and come up with other ways to deliver things for the trial. The timelines were also so tight that the actual drug didn't arrive on site until we'd had our first scheduled appointments to see participants. So we actually had participants in their cars waiting for hours on the first day. And I was very worried that people would be upset and angry, but they were also accommodating. And you know, this whole team effort of everyone coming together in the pandemic was really there with the participants as well. And we didn't have a single complaint. We had a carousel where patients came in, had their temperature checked, they were screened for COVID-19 symptoms, then they had their demographics checked, they were screened for possible COVID-19 symptoms, and then they had their, went on to be consented, have a history, physical examination, they had their vital signs checked, then if applicable had a pregnancy test, had their blood tests, COVID-19 swabs, pre-dose eligibility check, randomization, drawing up of the study drug or placebo by a completely separate blinded team, unblinded team, a doctor check prior to discharge, administering the vaccine, then monitoring for half an hour, then having more vital signs, then a doctor check prior to discharge, then a nurse check, and some education about using the vaccine diary, and then discharge. So that there are so many points in that carousel, and it took around 2 hours to complete for each participant. And the centre, as you can see in the background, it's not that big. I'm having to comply with social distancing as well. It was a huge challenge, and imagine having to do that carousel for every single participant. But the team were absolutely brilliant, and soon became very efficient at doing that and delivering. So let's just look at the numbers. So we had great support locally and nationally from comms teams. I appeared on BBC News Wales, and I appealed for people to approach us to get involved with the study. And within 48 hours of our various comms going out, we had thousands of volunteers. We ended up screening over 800 participants, and 490 of them were deemed eligible and randomized for inclusion. And this was over recruiting by around 25%, which was a fantastic outcome from the team, which I'm really proud of them. Each participant had the vaccine or placebo on day 0, and then they came back 21 days later for a booster. And then they came back again on day 35 and month 3 for safety checks. And there are also planned reviews at 6 months and 12 months and an end of study assessment. At the same time, as I'm sure you're aware, that we have multiple approved vaccines that have been deployed. So is it ethical to tell people who might have had a placebo as part of this study that they can't have a deployed vaccine? Obviously, the answer is no. So we've had a lot of, this is unprecedented. We've never had to deliver a trial like this. So we've had to change the protocol and make multiple changes throughout. And now we've had around half of participants unblinded, so that they have received a deployed vaccine if they had the placebo. And the others are now going to be enrolled in a crossover trial. So anybody who had the placebo the first time round will now have the active vaccine, and vice versa. So it's great news for participants, but it, it has doubled our workload as well. So without going into any commercially sensitive numbers, Novavax has been a tremendous success story. Officially, I think there are 110 staff on the delegation log, but actually, if you count all of the other staff who have been involved at the local and national level, there are well over 250 people who have helped to deliver this trial. We've been one of the highest recruiting sites in the UK for what is thought to have actually been the biggest ever vaccine trial conducted in the UK. It's a remarkable achievement considering where we were at compared to other established sites with established clinical research facilities. And this has actually been the largest study in terms of recruitment numbers and commercial income for any study in BCUHB history. Additionally, Wrexham, BCUHB, Public Health Wales have all had good PR as a result of this trial. And we have been highlighted multiple times at the UK level for delivering the trial so rapidly, effectively, and safely. And most importantly, the population of Wrexham has benefited from access to experimental medicines on a large scale like this for the first time. And this has been an important proof of concept that Wrexham can deliver large scale clinical trials effectively. So the results were even greater than we could have anticipated. Novavax has been shown to be highly effective against the original strain, the so-called Kent variant, and even against the South African variant, which we're hearing a lot about. Of course, there are multiple other vaccines already approved or in development, many of which have been developed and delivered in Wales, and you can see some of them listed here. But it really is humbling and feels an absolute privilege to have been able to help deliver these vaccines and help society. And I also feel proud of how involved Wales has been in delivering these trials. So what are the future challenges? So at a national level, Public Health Wales, the Welsh and UK governments have done a tremendous job to maximise vaccine take-up and improve confidence in the safety of vaccines. Vaccine nationalism, it just doesn't make any sense. That the nature of a pandemic means that if we don't vaccinate the whole world, new strains will inevitably turn up on our shores. And regarding new strains, work is ongoing to deliver vaccines against these strains for the coming autumn, winter. Worryingly, non-COVID-19 drug development has seen a serious decline in research activity. Many drugs in development have been paused to enable development of COVID-19 vaccines and therapies. There will likely be a boom of drug development once COVID-19 settles, but we are unlikely to have enough capacity to run early phase experimental medicines in the UK in the coming years. So how can we deliver such trials? Well, I have a vision to develop an early phase experimental medicines clinical research facility in North Wales. With a population of over 1 million across North Wales and the border areas currently lacking access to early phase clinical trials, we have now demonstrated that we can deliver such vital research locally. I'm in discussion with various local and national stakeholders to drive this forwards. And I'm mentioning this because I believe that the research legacy from COVID-19 will be a positive one that has enabled Wales to demonstrate collaborative work between the NHS and industry, raise the profile of NHS Wales and clinical research within Wales, but also leaves a legacy of developing and expanding clinical trial capability and research capability for years to come. So in summary, the COVID-19 pandemic has changed society and brought challenges, but with adversity comes opportunity, and we're now beginning to see the light at the end of the tunnel. Wrexham and my team have demonstrated that we can deliver high quality, safe and effective trials. And really, I believe that this is an exemplar of fantastic collaboration between NHS and industry, and has helped to raise the profile of clinical research within Wales and also develop future capabilities. And I've just included these because I noticed that these are the aims of the conference, and I think that these have nicely been demonstrated by the team. So thank you very much. And if you do want to get in touch for further information on anything discussed today, put something in the chat or feel free to contact me directly. Thank you.
Thank you very much. Thank you for a brief overview and summary of a tremendous body of work. I really do, I really do admire the effort you and your team put in, and I'm fairly sure that what you've just presented as a slide presentation will be a documentary in due course, celebrating the efforts that you put in and the benefits to the public in Wrexham in particular, but far more widely afield. So really do appreciate that. So what I'm going to do is, if you are around for a short while, I'm asking anybody who has any questions for you to put those in the chat, and that will allow us to move on to our next speaker, and move forward. But are you available for a few minutes in the chat?
Yes, that's fine.
Okay, children and cats and dogs permitting, I assume.
Yeah.
Okay, no, that is really great, and thank you so much for your presentation. So I'm going to hand over now to Andrew Brittle and Anna T. And I think Andrew and Anna are there on screen, so that's great. And the next presentation is focusing on what matters to people using the Macmillan EHNA to support holistic conversations. So it's great to have Macmillan Cancer Support here for this plenary session. And I will hand over the stage to you chaps. Thank you.
Oh, thank you very much, Gwyn. It's really nice to be here this morning. So good morning, everybody. My name's Anna, and my colleague Andrew will introduce himself, I'm sure, when we get through the presentation. But what we wanted to do is just share some, hopefully some innovative work with you this morning, and hopefully get some chance to chat to you again at some point in the future about it. So I'm going to start by telling you two stories. The first is about a conference I went to a few years ago, actually at the King's Fund, where I listened to a young patient talking about her experience of living with a chronic neurological condition. She asked us all a question, and that was, how many hours did we think there are in a year? Now, all of you sitting at home have got the sneaky privilege of being able to Google that answer, but as you can imagine, when we were in the conference, that was quite impossible. But the answer is actually 8,760. And she then asked us to guess about how many of those hours are spent on average by someone with a long-term health condition in direct face-to-face contact with a healthcare professional. And the answer might surprise you by being somewhat in the region of only about 2. Now, you might argue that this can't possibly be an evidence-based calculation, and I don't profess for it to be so, but needless to say, the message behind it's true, and that is that as patients, we spend a much larger proportion of our time looking after ourselves than we do being directly looked after. So my second story is about a lady with a gynecological cancer who remained distressed despite the full range of support she was receiving from her clinical team, and who, on probing, divulged that this distress was solely due to the fact she didn't want to have to get rid of her dog. On further asking, she shared that someone, hopefully not a healthcare professional, had actually said that she wasn't able to have a dog or own a dog whilst having chemotherapy. Of course, as soon as this became clear, the conversation could happen to disabuse her of this thought and discuss the benefits of actually having a dog to provide company, remain physically active during treatment and through walks, etc., and all was well. But what if that didn't happen? What if that conversation hadn't happened? And how often do we as patients know it's okay to ask questions of our healthcare team that are about our lives and not just about our treatment? How often as healthcare professionals are we truly able to explore all of these issues and be certain that we've been able to help address those things that truly matter to people? And this is where the holistic needs assessment really comes into its own. And we at Macmillan have developed, and we're rolling out an electronic version, which, whilst it's still in its early days in Wales as a whole, it honestly, and I feel quite passionate about this, has the potential to make a huge difference, not just to patients, but to everyone working in the sector. And yes, it's branded Macmillan, and it was developed to support a conversation for people with cancer. But it's not solely exclusive to cancer, because after all, people are people first and foremost, and not their condition. So the tool allows for exploration of other conditions that may be experienced by people with a cancer diagnosis, but also for people that don't have a cancer diagnosis at all. One of the first points to note is that at its basic, this is a tool. It's a tool to help support a conversation that's both held and led by the patient to talk about what's important to them at a point in time. There's no fixed time to do this and no set number of times it should be done. However, what we do know from our experience is that holding a conversation as close to, but not at the point of diagnosis, is considered really helpful by people. This is where issues such as money worries can be quickly addressed, such as referral to the Macmillan Welfare Benefits Advice Service, and hopefully resolved, freeing people up to concentrate on their treatment and keeping well. And we know, of course, that people's needs change during their treatment experience, which might be a good opportunity to use the tool again to explore whether there are new areas of concern. And in an ideal world, wouldn't it be great if we could move one day to a place where patients are actually asking for their own EHA, maybe one day. There are also bespoke versions being developed. So, for example, we're developing a version that might be more fitted to people with palliative care needs. And some services are even using the tool as an opportunity to better understand the patient and what is important to them in advance of the first contact, such as with the community palliative care team, so that the conversation starts that way with what's important to the patient and then leads on to the more clinically orientated questions. We also know that a conversation can happen with a range of people. It doesn't always have to be a clinical nurse specialist, for example. It could be an allied health professional, a support worker, and in some areas of the UK, such as in Glasgow, these conversations have actually been facilitated through link workers who run a service as part of a local authority. And interestingly, people feel more able to talk about wider issues such as housing with people who aren't necessarily in healthcare roles. And we have some indications that these conversations that happen with a support worker can actually be really positive. And this isn't a new process, and I'm not going to pretend today that it is at all. But what I should point out that it's different from other patient-facing questions, such as tools that measure outcomes, for example, PROMs. The EHA is at its basis a list of potential concerns that patients can say are relevant or not to them. It's not trying to measure outcomes or clinical changes in somebody's presentation. It's just about surfacing what matters to people. You might be aware of similar paper-based versions like the distress thermometer, but a really good thing about this tool is that it's online, and people who have access to a smartphone, tablet, laptop, they can all complete the checklist in the comfort of their own home, either on their own or with someone else to support. And we have found that this creates a much less threatening environment and have seen evidence of higher completion rates for some areas when done at home. And our experience has shown that people feel more able to open up about what is actually worrying them when they're at home, especially for men who previously might not have raised issues such as erectile dysfunction, for example, in a consulting room. Being able to think about EHA at home has actually facilitated a more open conversation, which all means at the end of the day for the patient, there is the time to think about the concerns that matter to them, And they're able to think about this when they're in their own home and not feeling that they're taking up time from somebody in the hospital and thinking about the next person that's waiting in the queue. And there's also a very clear indication of permission in the sense of being told, yes, it's actually okay to talk to us about money or sleep or relationships. And we might not actually have all the answers for you, but we can listen to you and hopefully point you in the right direction for support. We know this makes a difference for professionals too. We know that these are all the questions that people are asking already. But we also know that to ask each of those questions in turn actually doesn't really happen in practice, and it can be quite challenging to do that in an appointment, and it can sound quite robotic and not focus on that individual, and then ends up being more of a tick list rather than an opportunity to actually say, this is what matters to me. And this does take time, of course it does, and it's always one of those concerns that people have when we start talking to them about such tools. But that's the beauty of it. Because it's a tool, it can be picked up and used by the teams operationally best so that it fits. We've also experienced that when teams that really do embrace this and use the tool well, that whilst there might be some additional time that's needed to be spent at the beginning, actually when the conversations start happening, in reality, overall it means that actually because things are highlighted much sooner on, people are able to address the issues that matter, which ultimately frees up time in the future. And this isn't just about hospitals either. I spoke at the start about how little of a proportion of our time as patients we spend in direct contact with services. And there's so much potential at community and primary care level to support people differently. And this could be done through a range of different professionals, practice nurses, GPs, social prescribers. We've all seen during the pandemic the level of community support that really is possible. And we've seen systems and processes and people respond really well to working differently and better utilising the technology that we have at our disposal. And whilst I'm sure that many of you, like me, bizarrely relishing the time that we can actually commute again, I don't know when that ever happened, but we have all adapted to working differently. Like this conference is a really good example. And I'm sure we'll see less of a need to actually go into hospital to receive all of our care interventions in the future. And we'll be embracing the outbound model of care a lot better, and the Macmillan EHA could very well fit into this new world that we're inhabiting. I hope you would agree this is an exciting improvement. It's about bringing care closer to home and starting with the patient. It helps us to engage at the appropriate level across the mix of our patient-facing teams, and really encourages people to work at the top of their licence. Our ultimate vision in Macmillan is that every single person in Wales who is diagnosed with cancer is offered the opportunity to have the conversation about their holistic needs. Doesn't mean they have to have one, because we all have a choice, but we absolutely believe that this should happen. And there are some really, really good practice examples happening already, and some incredibly keen healthcare professionals in Wales who want to make this happen. And this is a tool that I absolutely believe can transform the patient experience. So do you want to hear a bit more? I'm going to hand over to Andrew now to talk through a little bit more about the actual tool. Thanks, Andrew.
Thank you, Anna. If the slide will actually move on. Yes, thank you. I'm Andrew Goodall. I'm the EHA digital product owner for the EHA tool, which means really that I just look after it and make sure that it gets developed properly. Now, all of this work was based on a study that was done by the National Cancer Survivorship Initiative back in 2011. And they were really looking at the fact that because of the increase in survival rates for people living with cancer, there are about 2.5 million people who had survived cancer and were now in that stage afterwards where they could potentially have long-standing problems arising, and where in fact cancer is becoming more of a long-term condition. And that's particularly important because as we move towards 2030, we're expecting to see 4 million people who are surviving cancer and have ongoing needs. So really this piece of work was about looking at how those people's needs can best be met. And obviously the old model of clinical follow-up wasn't something that was scalable as you start to involve so many people. And one of the things that they come up with was the use of the of the holistic needs assessment. Now, the idea with that is, as Anna was saying, to find out what are the most important things to that individual, to find out what's on that person's mind and what's most important, so that by working with the key worker, they can start to resolve some of those issues. Now, initially, Macmillan worked with a range of agencies, involving patients, involving staff, also involving the NHS itself, to look at what would be a suitable model. And you can see on the screen there in the background, there's a thing called the concerns checklist. And what we did initially was we started off with a paper version. Now you can see there's about 53 individual concerns that are being raised. And that is quite a complicated piece of paper if it's being handed to you. Not always the easiest thing to use. It's also very difficult to get a sense of what are people's most important needs. So over the space of a couple of years, Macmillan worked with a developer to come up with an electronic version of the holistic needs assessment. Now, the idea with that is that the professional is inviting the individual to complete an assessment. We built it so that it can be done on any device that's connected to the internet and that's got a browser. We've taken that approach rather than developing an app, simply because most people will only tend to get one of these or two of them at the moment. And it felt like a lot of complication to get people downloading something just to follow a process once. It also gives us the greatest flexibility because it means that it can be done in a clinic area. And what we used to find historically, I say historically, going back to before coronavirus, what we used to find was that about 2/3 of assessments were being completed in a clinical setting. What we're finding now is that about 2/3 of them are being completed at home. So we've tried to build in that degree of flexibility right from the beginning. So the idea with this is that it's as simple to use as possible. As it says on the screen there, what we found is that even though it is offered by the professional, the range of people who are offered the tool does follow cancer incidence quite closely. So it is giving us a reasonably good idea of the concerns being raised by cancer patients. It takes about 7 or 8 minutes for the average patient to complete it. And as it says on the screen, we have 53 concerns on the list, and those are sorted into physical, practical, emotional, spiritual, and family domains. So you can just about see, if you're lucky, things like breathing difficulties, passing urine, constipation on the physical list. On the practical list, we might have things like taking care of others, work or education, money or finance. Emotional concerns might be things like uncertainty, unable to express feelings, thinking about the future, and so on. So a broad range of concerns, the idea being that the individual who's completing this can go through and identify for themselves what are the most important concerns. And we do find it's important that it's the individual doing that because, as Anna was saying before, if they're sitting in front of a nurse or a professional, then that can sometimes influence the kind of concerns that they're identifying. So when it comes to the care plan, well, the person sitting at home, in this case, Andrew Test, person sitting at home has completed the assessment, and as soon as they submit that to the system, the nurse will be alerted, and the nurse can then go in and have a look at some of that person's top concerns. Now, although it is possible for somebody to highlight all 53 concerns, in practice, what happens is that people identify about 4 or 5. Some tumour sites identify more, some not quite as many, but on average, it's about 4 or 5. And it's then up to the nurse, in discussion with the patient, to take that forward and produce a care plan. Now, the idea with the care plan is to look at maybe the top 2 or 3 concerns and to identify potential resolutions for those concerns. Now, some of those might be advising to go and see the GP, advising to keep a food diary, signposting to a local support group. Some of them might be more clinical, so it might be actually changing the patient's medication. What we find, though, is that on average, about 2/3 of the actions are things for the patient to take away with them, and about 1/3 for the nurse. That was certainly one of the concerns right back at the beginning, that this would inundate the nurse with a whole host of things that they would have to do at the end of the discussion. But actually what we find is it's the patient who takes away more of those actions. One of the things that we have built in recently, obviously Macmillan has a very comprehensive website, a huge resource for people living with and beyond cancer, and people affected by cancer, so their friends, family, carers as well. Huge amount of information on the Macmillan website, and one of the things that we've done is condensed some of that information and attached it to the EHNA, so that, for example, if somebody identifies thinking about the future as a concern, then there's an information sheet about that on the system. And by ticking a box when they're writing the care plan, that's then made available to the patient for themselves. So how does the patient get the care plan? Well, you can see in the background there what the care plan looks like. It is really acting as a record of that discussion that the individual is having with the key worker, with the professional. And I do keep changing how I'm referring to that person, because what we find is that across England, Wales and Northern Ireland, it tends to be a nurse or a support worker or a care navigator who's actually providing that conversation to the patient. But across Scotland, we find that it tends to be in social care. It's very successful in social care there. And I think when I come on to the next slide and talk about the data, we'll see why that might be the case. But in general, about half of the people who have a care plan written receive it on paper. And what that does is it gives them a copy of that discussion they've had with their key worker. They can take that away and they can see those actions that the key worker is going to do on their behalf, but they can also see the actions that they are having to do for themselves. So it's supporting the idea of self-management right from the beginning, which then allows the person to take a bit more control and feel a bit more empowered in managing their own condition. We've also relatively recently added a patient portal, and what that allows is for the patient to download their own copy of their care plan as a PDF file anytime they want to. And one of the really useful things with that is that we know that the patient's care can move between different care providers, between different hospitals. What that allows, because it's all connected together by NHS number, is all of the assessments and care plans that the individual has will be joined together on that portal so that the individual can see them. And again, as you can see just at the bottom of that screen, there are some help topics at the bottom of the portal so that if they want more information without having to go back to their nurse, they can go to the Macmillan website to get it. Now, the last slide from me is, what do we do with this? Well, as part of EHNA, Macmillan has no access to identifiable information at all. But what we can see is the overall trends. And what I've actually done on the slide there is I've actually used Wales data up to last Friday. So we can see on that the range of tumour sites. We can also see down at the bottom there, very importantly, what were the top concerns. So in Wales so far this year, the most common concerns have been tired, exhausted or fatigued, questions about diagnosis, treatment or effects, pain or discomfort, thinking about the future, worry, fear, anxiety. So those may not be very much of a surprise to anybody, but what that does do is it puts the numbers behind it. It gives the evidence that then allows you to look at what services might be missing, to look at what resources can be put in to support these patients better. And as Anna was saying, it doesn't always have to be cancer patients. As we're moving more towards a community setting, moving more towards palliative care in terms of the new assessment tool, it could be anybody, and it could give you a better idea of what resources might be needed more generally. The final thing I want to look at, just in that bottom corner, when instead of looking at the most common concerns, we start looking at the ones with the highest average scores, we can see that we get thinking about the future, sleep problems, uncertainty, worry, fear, anxiety. And in general, what we find with that list, looking at the scores looking at the concerns with the highest scores, it tends to be the non-clinical ones that are at the top and that are the highest. So I think that's part of the reason why it seems to work so well in a clinical setting and also in social care, is because it's not always the clinical concerns that are the most important. Sometimes it can be these non-clinical things that can be resolved by anybody who has the right training. So that's all from me. If you do have any questions for either of us, please do get in touch. Thank you very much.
And thank you very much, Anna and Andrew, for that excellent presentation. Really interesting stuff, particularly interesting that you, well, firstly, congratulations on being able to innovate at all in such difficult times, not least of which you've come up with a really valuable product and service. So, so congratulations on that. It was really interesting to see how the creation of data and the creation of all that information and the knowledge didn't automatically result in increased workload and increased actions for the clinicians. Some of it was empowering the patients and carers to be able to take away more knowledge and be able to provide those actions themselves. So I think there's a lesson to be learned there for everybody who is concerned that data might just equal increased workload. And it was also incredible to see the new learnings. As you said, Andrew, there are those assumptions that have been made around the concerns and issues that patients are facing are possibly well known anecdotally, but to put data behind them and to be able to rank them and to identify just how important they are is really important work. So so thank you very much, Anna, and thank you very much, Andrew, for that presentation. Are you around so that we can point people towards you in the chat?
Yes, we will be around. And actually, one thing I forgot to mention is that at some point this morning, we will have the 200,000th assessment completed on the platform, which is a huge milestone. And obviously, that's a huge amount of learning we can take from that.
That really is incredible. Thank you very much, and congratulations on that.
Thank you.
So now I move probably not too far away in topic area, but we move to the new Valindra opportunities for research and innovation. And I should have the Valindra team popping up on my screen now. And that's David Powell, Hugh Llewellyn, and Jacktina Abraham. So Hugh, we're hoping that HU120074 is you, and if so, thumbs up from everybody. We will hand over, and thank you very much for providing your presentation.
Excellent. Can you hear me clearly?
Yes, we can hear you clearly, and
okay.
We can see your slides.
Excellent. I think Isabel is kindly putting up the slides, so thank you to Isabel for that. Yeah, my name's Hugh Llewellyn. I'm joined by my colleagues. You can see there, Jacinta Abraham and David Powell this morning. Delighted to share with you the work we are doing in South East Wales, cancer services, and particularly with a focus on research, development and innovation this morning. So if we have the next slide, please. So in terms of the flow, I'm going to set the context of our work, particularly the focus on creating value through collaboration and partnership. Jazz will then pick up the research and development and innovation ambitions of Valindra and the wider community, and David will then provide a focus on the exciting opportunities offered by the new Cancer Centre. Next slide, please. Perfect. So what is South East Wales Collaborative Cancer Services? So I've split the slide into two parts. Firstly, a focus on the regional whole system. And as you can see, it spans the whole gamut of the cancer pathway, from prevention, detection, through rehabilitation, through to end-of-life care. And particularly put a focus in there on the work that's being done collaboratively around regional digital transformation, and also the focus on research, development and innovation, which more later. On the right, you can see the focus of the work around Velindre and its Transforming Cancer Services programme. Exciting investments and leadership of work of change there from the new Cancer Centre. David will provide a focus. The Radiotherapy Satellite Centre in Neville Hall, through to a range of other significant investments in equipment and digital, with a particular focus on Velindre Future's R&D, of which more later from Jazz. So next slide, please. So in terms of the work to drive value and a collective value across the region, I wanted to share the work that's been done to set up appropriate leadership structures across the region. And in that regard, we've collectively established with our 3 partner health boards, a collaborative cancer leadership group chaired by the Chief Executive of Cardiff and Vale. And that consists of executive directors from the 3 boards and cancer clinical leads and other specialists. And the task is a challenging but simple one, to provide whole system leadership to drive value and improvement across the region. And in that, you can see a focus on coordinating investment decisions, driving best practice, fostering partnership and collaboration, facilitating RDI, particularly the opportunities around the 1.5 million population of the region, and drawing our resources together around technology and digital. Next slide, please. So as I said at the outset, partnership and collaboration is important to us. And when we say partnership and collaboration, we mean with all partners, all stakeholders, all sectors. One of our leading clinicians, Dr. Mick Button, has a Behrell Fellowship to lead the establishment of a collaborative cancer community across the region, with a particular focus on behaviours and interaction and relationships. We are delighted that our new hospital includes plans for a regional collaborative centre for learning, technology and innovation, and that will touch on research, on education, with very much with a patient focus, improving care in practice. We're also delighted that we're in the final stages of establishing a 14-year relationship with a major radiotherapy provider that will also include a research partnership and a range of significant research opportunities in the field of radiotherapy. And all of this is being done with engagement across sectors, particularly as we are today, sharing it with a wider audience outside of health. And I wanted to emphasise the excellent relationships that the Trust has and the wider community have with our universities in South East Wales, and the opportunities to align collaboration with our innovation and our research and development in health. Next slide, please. So in terms of the value, the value is significant. The opportunities are significant. So a regional approach to 1.5 million population, coupled with the hundreds of millions of pounds of investment that are coming into cancer services in South East Wales over the next 5 years, provides a unique opportunity to drive significant change. We're very focused on the range, depth and integration of RDI activities in all our services, and developing an RDI culture that will be sustainable. We're very drawn to becoming a centre of excellence for whole system collaborative change. We're mindful of the role of digital transformation in that, and we believe we can create value for all our partners in that endeavour. I've mentioned the academic institutions, and importantly, but not and finally, in doing so, we're placing patients at the centre of that activity, and we're really driven to actually improve their opportunity to participate in research development and innovation, and also including clinical trials. So as a quick canter through, I apologise for the brevity, but we've got a lot to cover, and I'm delighted to hand over to Jazz to continue the story in terms of RDI. Jazz.
Thank you, Hugh. Good morning, everyone. Assume you can all hear me okay? So I'm a medical director for Velindre NHS Trust. I'm also the lead for research, development and innovation. And you're going to have 5 slides from me on the recently developed cancer research ambitions for Velindre Cancer Centre. Now, research has always been and continues to be central to the work that we do in the Cancer Centre. But the promise of this new hospital now has really focused the minds and allowed us to develop a research strategy, which I'm delighted to be able to share with you today on a few slides. So we are saying that our mission is to become a leader in cancer research nationally and internationally. And in doing so, transforming the culture of our organization so that every patient, every staff member has the opportunity to engage with research if they so wish to do. And that is, that's a big ambition, but we do believe that it is central to our ethos. And with that vision, a vision to work with patients and partners such as yourselves to design and deliver this research that has an impact, which is to improve survival, to enhance the lives of cancer patients living in Wales and beyond. And we heard a bit about that from our partners, Macmillan. So do think about where you might be able to add value in this conversation, and please get in touch with us. So we've developed 4 themes and 5 aims. And the 4 themes are to advance new treatments, interventions, and care. So whilst we are already participating in a myriad of national, international trials in Velindre, we have ambitions to take that further, to develop, for example, complex early phase therapies and including advanced therapies. And to do so, we are planning to develop a footprint on the Cardiff and Vale site in conjunction with Cardiff University to have a sort of tripartite cancer research facility. And that's an exciting new development that we hope to bring back information on in the future. Our next theme is to put patients first and center of everything we do. So long as we maintain that principle, I think we will get the right results. We intend to drive translational research, and this is an area where we feel there is quite a lot more that we could be doing in improving connectivity between the lab and the clinic. And so needing to work closer with our academic partners to do that. And then this 4th theme, which I'll come back to, which is embedding research and innovation within the organizational culture. I think only if we truly understand what that means, will we succeed with our mission and vision. So next slide, please. The 5 aims that we have developed are important to consider because we will need to be able to measure these aims and inform you whether or not we've been successful. And it is here where you as partners may also help us and may be able to add value. And looking at the breadth of the topics that we're covering in this conference, then I think it will touch on many of these areas. So starting with patient experience and care, how do we enhance that? How do we improve patient outcomes? What do we mean? How will we measure this? And equity of access, reducing variation, really important. We want to accelerate implementation of new discoveries. That means shortening all the steps in the pathway, being more efficient, demonstrating the impact of our research, and then the building of capacity and capability for research across South East Wales. We want to attract workforce. We want to really understand how we can exploit this really ultimately for the people of Wales. So next slide, please. In terms of the theme on embedding research and innovation, I thought perhaps just a little pause on what this might mean. And we have considered 4 areas really, which we would need to hone down on to understand this better. I think first of all, the workforce. Unless we address to ensure that our workforce has time to deliver research in a coordinated and systematic way, and that means people across all multidisciplinary groups need to have time in their job plans to deliver research and innovation and to have set out academic pathways. Unless we do that, we will not be able to reach our full potential. So that requires careful planning. In the digital space, there is a lot happening in this area, particularly around digital leadership. We've set up an academic partnership board. I think Hugh just mentioned that a minute ago. And with that platform, we've been able to develop a number of different partnerships with academia involving all the universities in Wales. And that's led to, I think, a really exciting combination of taking a sort of service enabler and pairing it with academia and seeing what happens. In innovation, perhaps is more recently formed at Velindre in terms of its structure, and we've brought it into the research space, so it's joined up. And David will tell us a little bit about what the new hospital might bring to us in this space. So we look forward to hearing about that, David. And then the impact, as I said, how we measure these changes to really see how we're achieving our goal. Next slide, please. We can only do this really with, as long as we sort of link up our patients with partners as yourselves to achieve the breadth of the research and innovation that we intend to see. And the people include our staff, students that come into the organization, volunteers. So it's really about enabling everybody to be part of this. And I think you, representing our partners today, we do want to consider how we can work closer with yourselves. And I'm sure there will be opportunities here that you will be thinking of, so do get in touch. The final slide for me then is really about our next steps. So, you know, having this opportunity today is great to be able to just very briefly, hopefully whet your appetite that we're keen to engage. And this has got to be a sort of systematic plan for staff. Our health board partners are very, very important here. Our academic partners, Welsh government, charities, industry, and we do want to bring the outside in. How do we benchmark against, you know, other sort of cancer centres such as ourselves, like the Christie and the Marsden? What do we learn from them? We intend to develop a plan, and because that plan is not yet formed, you have the opportunity to shape that, and then in doing so, realise our mission and vision. So thank you very much. I'm going to hand over to David now to tell us a bit more about the new hospital.
Thank you very much, Jazz. Hopefully you've got an idea of the picture that's been painted by Hugh and Jazz, that there's a lot of ambition around the new Velindre. And I've been doing this a long time now, developing new hospitals. And a couple of things that will stick in my mind is it doesn't happen very often. So it's a very special opportunity. So you want to make the most of it. And secondly, it does unleash a lot of energy and a lot of opportunity to generate new thinking, new thoughts. And it's about being more than a hospital. And both Hugh and Jazz talked about reaching outwards, so the opportunity to bringing people into the opportunity. Just starting with the ambition piece of it here, and we're not being shy here, so we are setting ourselves out to do something quite ambitious here, and so we're looking at being the greenest hospital in the UK, the smartest hospital in the UK, and the most human hospital in the UK. So that's our stall that we're setting out with the new Velindre. Next slide, please. So in terms of the greenest hospital, a number of my colleagues in the new hospital business are looking at this area very hard at the moment, but it takes different guises, but we want to make sure this hospital is low energy. So we want to minimise the amount of energy we're putting out in order to run the operation. In tandem with that, we want to be zero carbon, and that is quite a challenge. We're a massive user of carbon in the health sector, but we would really like to see what we could do here to try and get down to zero carbon. And it's a challenge, but we think this can be done. Associated with those harder things, there's a softer opportunity here. We're building the hospital in a nice place, a lovely setting for cancer patients. And we want to make sure that in the campus we're putting the hospital, that we are looking at nature and biodiversity. And we would like to encourage that alongside the hospital. Then there's community benefits. We're in a part of town where there are quite a number of opportunities there, but what could we do with the development to generate benefit and upside for the local community and for the broader community here? So what could the building bring in terms of opportunities there? And the last one is linking it all to the future generations. And it is very interesting coming into Wales, where looking at the future generations has been put into an act. And so there's a whole sort of focus on what we do now, how does it ripple on and impact upon those people yet to come. Next slide, please. The second area is the smartest hospital in the UK. So we would like our building to be, and this does link across, but we'd like our building to be intelligent. And that could mean different things. but we would like the building to be able to interact with people coming into the building, so that it's aware of people and responds accordingly. There are a number of opportunities here. There's a picture here which I've put up here from my previous scheme in Alderhay, where we in day surgery put a big immersive wall into day surgery, and when you're waiting, you can launch you can draw your own fish or your own marine animal, and you can launch it into the aquarium, and then you can watch it going round until it's then your turn to go into day surgery. And for the kids, it's very engaging. The point about it being is it's more than just a display. It's actually interactive, so you can interact with it, and it knows you're there, understands you're there, etc. So that theme, I think, of the building, understanding you're here, and you can interact with it, and you can see how you're interacting with it, I think is a very strong idea. So we would like to bring that idea in. The idea of having immersive environments is being developed now. The idea of bringing 3D into the building world is becoming more and more of an opportunity. And as Jazz says, with the innovation side of things, then there's some techniques and technology there which we'd like to bring in. I mentioned Alderhay, but underneath Alderhay we built a bat cave, and there are now 20 people in the bat cave who are inventing things underneath the hospital once we opened it. And the idea that that innovation carries on once you've opened the hospital. There's a whole point about connectivity, and again, the first presentation, which was very interesting this morning, that talked about COVID and what that means, but that has actually given a bit of stimulus to connectivity and how you use digital techniques to connect all of us up. So there's a theme there that we'd like to look at. And then supporting pathways, and again, both you and Jazz talked about the patient pathway, the progress of patients, how they move through the whole system, and again, looking at how we might have a smart hospital that supports that and generates digital solutions which support the pathway. Next slide, please. The Most Human Hospital, and there's a number of people that I've been talking to recently who are sort of regretting actually some of the new hospitals or some of the new buildings that have been put into England in particular, where they don't feel particularly human. So they have a functional element to them, but maybe miss the opportunity to sort of to pick up that human thread. And if you look at Velindre, particularly where we've got patients with cancer, where people are going to be feeling vulnerable in a particular part of their life, the idea that building has to respond to people as a human is I think, very important. Again, I put a copy here of Alderhay up on the screen, but the idea was in there that you developed a campus or a set of buildings that looked at, number one, the patient experience. So what is the patient experience as they come into buildings? What are you feeling like when you come in, and can we do something to wrap around you and make that experience more relaxing and something that is more communicates with you as a person? And then not underestimating the impact upon the staff. In my first scheme, about 20 years ago, I worked with an anaesthetist, and he was always talking about avoiding the burger bar experience, where the front of house looked nice, but the staff were all sweating away in the kitchen. So the idea that the hospital itself would generate a great experience for staff as well, so that the environment meant something for staff, and again, stimulated them up while they're at work and gave them something, a pleasant place to be. The third sort of axis on this is the public experience. So not building something that's discordant and therefore creates a bit of a something that doesn't fit. Again, I've worked with architects talk about this spaceship landing experience, where you get this flashy building suddenly sort of turning up in parts of town. What you really want is something that blends into the local area. And because we're in a site where we are, we want to make sure the building blends and adds rather than detracts to the local surroundings. And linked to all that is art and culture. And there is quite a lot of well, I mean, Wales itself is interesting. There are lots of a depth of culture, a sense of culture in Wales, a sense of what Wales is, and that's something that we would like to stimulate and bring into the building. And there are opportunities to do that as we go. And last slide, please. So just come back to the process. So what we're doing at the moment is looking at the outcomes. So in order to make this work, we have to understand what the outcomes are. And this is a subset of the pieces that Hugh and Jazz have been talking about, but an interesting subset. So what would be the smart outcomes that we would like to look at for the hospital that we could measure? And then can we start to look at the process as well as just the outcome? So again, we intend to engage very deeply with the hospital. So we're looking to really bring people into the process. And can we measure the impact of that engagement? it's not something that's been done before, hospital development, and it's an it's an underdeveloped area. But how much does the benefit, the impact that we undertake impact upon the final solution? So there's lots of sort of general sort of sense about this is a good thing to do, but what does it do to the end product? We'd like to do it prospectively, and again, one of the problems with these new hospitals is that we do the new hospital, we're all supposed to do post-project evaluation, and I'm one of the biggest culprits. We then move on and do the next project, we don't do it properly, and the money runs out. So there's a very shallow database of knowledge around new hospitals. So the research is limited to a couple of sites, Texas and one or two other parts of the world have done something, but it's pretty limited. So could we do something prospectively whereby we set ourselves up now before we start, and then measure as we go, and make that interactive. So again, we'll come back to this engagement piece, but we would like this engagement to be very interactive. So we've been linking up with an organisation called Down to Earth. We're not a health organisation, but they develop sort of housing type schemes with people, and we're using them to do some citizen surveys, so involve local people into surveying the site and surveying the campus before we start. And we're going to use that to determine what we do. We've also been engaging with local schools through one of our colleagues, Carl James, has put us in touch with local schools and the council. We're going to get local schools to build the hospital in Minecraft first, so we'll see what they come up with, and then we can use that to sort of maybe help guide and steer what happens. It could be very interesting. See how that goes. And then also get the local people involved in developing the community benefits packages. So I talked about the idea of wider benefits in the hospital, but getting some engagement and interaction into what those packages might look like. Can we get contributions to local sports clubs? Can we grow produce on the campus and use that produce in markets or in the hospital itself or in the community? Can we get local people having events and activities on the site, which we could then facilitate? So there's a whole series of ideas there, but what do people really want? And then just to sort of finally make this multifaceted. So again, the sort of the opportunity and the invitation that we're obviously using today as a sort of setting our stall out is the invitation is there. We'd like to look outwards, as you probably get the sense of, that we're looking to work with people and engage. And so the idea of doing a multifaceted, multi-institution, an open source research endeavour whereby various organisations or people who are interested could get involved, and that could mean medical students. We've already had some medical students doing some studies on the Green Hospital, which has been very interesting, through to sort of multi-stage studies, big studies with institutions. So that's the invitation. Anyone who's interested, we'd love to know about it and see if we can work with you in taking the opportunity. Thank you very much.
Thank you very much, David. What a really exciting project, and thank you for sharing that with us today. And thank you to the whole team. I mean, we've just seen a presentation which, again, very briefly just covered. I felt that collaboration came across in everything, in all three presentations. So I really do appreciate that, and that really is a characteristic of our Welsh health and social care system, and also our life science sector, is that collaboration really is one of our key strengths, and that just came out of all three of those presentations. Tremendous ambition to be leading in international research is both ambitious and entirely appropriate. We've got the facilities, we've got the brains, we've got the excellence in research. So really, why shouldn't we be leading internationally? So it's very exciting to hear about that. And then, wow, the new hospital plans. I want to be. I definitely want to go on the immersive wall. So please put me on the invite list as soon as I can have a go on that. That was incredible, and I'm quite tempted to join in with your Minecraft project as well. So so really exciting, and really the new hospital is obviously an asset for Wales and an asset for the UK. So something that we really should make the most of. As you said, David, it's not something that comes along very often. So so we really do have to make the most of it. So thank you very much for that. If you have any questions for the Valindra team, please put them in the chat and or address them directly. It would be great to see some interaction going on in the chat after this presentation. But I'm now going to move on to our next presentation, just down the road. And it's Dr. William Behrell of Cardiff and Vale University Health Board, Assistant Director for Innovation. Welcome, William, and I believe you're talking on the Dragonheart Institute, creating space for radical innovation across organisational boundaries. So I'm seeing that collaboration and innovation are a continuing theme. So the floor is all yours, sir.
Gwyn, thank you very much indeed for the invitation, and good morning, everybody. Well, gosh, what a pleasure to follow on from all the previous speakers, Orod, Anna, Andrew, the Valindra team. Fascinating, and I agree, the aquarium, that's brilliant. I'm here to speak for the next 15 minutes on the Dragonheart Institute. And thank you, Isabel, for these slides. If you'd move to the next one, please. The Dragonheart Institute is an initiative that was conceived about a year ago, hot on the heels of the construction and operation of the Dragonheart Hospital. I'm going to tell you a bit about how that idea was conceived and what we want to do with it, both in terms of what we've achieved in the last year and where we wanted to go next. So if you'd move on to the next slide, please, Isabel, thank you. As you can see, the vision for the Dragonheart Institute is about spearheading innovation and being a catalyst for change, as are many of the institutions and entities around us in Wales. And in that sense, we're joining in. But I think what we're doing most of all is creating a space rather than an entity for the exchange of ideas and for radical collaboration that recognises that the system we're in, though it has many strengths, is in large part failing in the sense that we're consuming an ever-growing proportion of Welsh Government revenue. The workforce is exhausted and stretched to breaking point and was before the pandemic, and that we're embedded in a society itself which is struggling to confront all sorts of emerging threats, many of which have a health focus, the latest of which was, of course, COVID-19. So in that sort of broad socio-political context, what does a 21st century health system look like? We want the Institute to be a spearhead for innovation in three ways. And these are three lessons that we learned from building the Dragonheart Hospital, which was 2,000 beds in 4 weeks. We did that by bringing together a team of multiple stakeholders, all of whom, of course, brought with them their own perspective on the world, but also on the workplace. And in a wonderful way, that gave us a sense of immense job satisfaction. A team emerged from that was the sum, or more than the sum of all those parts, and which created a huge sense of energy, but also, of course, gave us solutions to problems that we wouldn't have conceived on our own. So that was a real reminder to us of the value of that multiple perspective approach to problem solving, and of course reminded of the classic sort of Einstein quote that you're not going to solve problems with the same thinking that created them in the first place. The second lesson we learned from that was really about peer support, that actually in generating that sense of team, there was a shared narrative, clearly very explicit and shared purpose, but it went much broader than the NHS. We worked with 30 separate companies. We worked with the council, we worked with academic partners, the military, the Welsh Rugby Union. The NHS was leading it, but all of these partners felt as if they were doing their bit. And I think there's another lesson to be reminded of here for us, which is that we're embedded in a wider community. Of course we are. People don't want to be bystanders. They want to participate in making their communities healthier. And in the context of a healthcare system that seeks to champion preventive medicine, what can we do to harness that energy? So the mission is these three things. So it's growing this cohort of leaders, nurturing through the system, connecting them to other parts of the system so they're thinking in tandem. It's about building that network globally, bringing people to Wales so that we can participate in and help lead cutting edge thinking, and do that horizon scanning piece where we know what's coming down the line and we can prepare for it. And it's about engaging with the people around us in a more creative way. I mean, let's acknowledge that the NHS is not always the easiest organisation to work with, and certainly that's been my experience of talking to people who are trying to set up projects in the community. So this, I hope, creates some of the atmosphere, recreates the atmosphere in which the Institute was formed. We did this intense surge effort, and we want to ask ourselves the question, if we could do it then, if we could apply that focus to other health problems, what could we achieve in the future? So Isabel, next slide, please. The so-called wicked problems of tomorrow. Clearly, zoonotic disease is chief among those, and COVID is what we're still grappling with and what we're likely to continue to grapple with for years to come. But what next? We would be naive, of course, to think that that was the end of it. And we are all preparing in our own ways for what happens next. And we've just had a brilliant presentation about what a hospital looks like in that context. Working with people across the spectrum to anticipate those problems and to try and prepare ourselves for them. How does a vast organization like a university health board of many thousands of employees, how do we do that? We're not geared to change in such rapid and radical ways. There are, I think, examples of parallel operating structures that almost serve as the pioneering element or the probing element that can, or a tug that can pull that ship in a different direction. This, of course, is nimble, it's agile, and it requires thinking in a new way. So how can you create the conditions in which those new approaches to thinking and new approaches to work not only be conceived of in the first place, but actually take root? And I suppose just to dwell on these objectives for a moment, not to lose sight of the fact that we're using public money, that we are, after all, public servants, but we need not be limited by public purse. We're surrounded by companies who are increasingly aware of and confident about talking to their shareholders about social purpose. They don't want to be bystanders, they want to participate and be partners with us in these solutions. So what sorts of financial innovations can we look at to enable that to happen in a more consistent fashion? We touched there on stakeholders, and of course, talking to staff is as our chief asset. The health board, Cardiff and Vale, we have 14,500 staff. I think across Wales, we have an incredibly high proportion of the workforce that are employed by the public sector. We are, as a general rule, exhausted. Tenure is quite short, particularly in senior positions. Retention's tricky, recruitment's difficult, improving in some areas. Are we really investing in our workforce? And when we look at the budgets, a very small proportion is often allocated to doing just that. So I think let's put our money where our mouth is, and let's work out how we can cultivate that sense of family in such a large workforce. We talked about how we engage with our citizens in a more active, participatory manner. We've had some brilliant examples of this morning of people already doing that. And Minecraft is a great example of how schools might participate in a hospital build, for example. We've talked about how we might work with partners, and we talked about the commercial partners that might help serve to enrich the vision and actually resource something that would be infinitely better than we could do if we relied on our own public purse. And investors, people with a philanthropic social bent, people who are willing to invest in the future, and how can we make it easy for them to do so? So this continues to build the context, I hope, for this emerging institute. Isabel, next slide, please. Thank you. I'm only going to linger on the slide very briefly to make the point that the last year as a health board has shown us how extraordinary our staff are, not only in terms of the day-to-day commitment that they've shown, but I suppose more in terms of the ingenuity and solidarity that's emerged. This, of course, is not new, but we've been reminded of it, where people have taken it upon themselves to be bold, to innovate, to do what's necessary to get the job done. They've often done so at not inconsiderable sacrifice to themselves, to their family, and we need to recognise that comes at a cost. We need to support that and create the conditions for that to be a gear which we can find when we need it, but not a gear in which we find ourselves the whole time. Otherwise, everyone's going to end up at the end of this in a heap. Next slide, please, Isabel. Thank you. So we also touched a thing earlier this morning on the All Wales Innovation Study, and feeding into that is our own discovery report, which is a summary of the innovation that's been produced across the health board in each of the different sectors. And one of the ways we want to take this forward is by creating a big tent. This is what you see in the bottom right-hand corner of your screen. So it's a virtual reality environment where you can essentially hire your own tent. And in that tent, you can have permanent content. You can create that either in terms of videos, presentations, but you can also run workshops. And when the tents are not in action, the big screen here, on which you can see a picture of our Chief Executive, Len Richards, will be a big picture of all the activity going on in the tents behind it. And we hope very much in working with our stakeholders, as we heard just a few minutes ago, be they citizens, partners, investors, staff, each of these tents will be a symbolic and virtual workspace for a joint venture. So you might imagine, for example, one tent being on social prescribing or another tent being on planetary health. How can we, in the context of climate change, innovate to make sure that we're not just meeting our requirements, but that we're exceeding them? And how radical can we be, and how can we push that as far as it will go? So this is one example of how I think in the last year we've learned to work in a new way. And over the next year, we'd like to invite all of you to participate with us, join us in one of these tents, and let us support you in some of the ideas that you want to take forward, and some of the things in which you'd like to invite the NHS to participate in that perhaps we haven't before. Isabel, next slide, thank you. So I think within the next few years, these are the sorts of statements we would like our staff and our partners to be saying. We would like to have a more confident grasp of what's coming down the line and how we're prepared to face it. We'd like to be talking about not just young leaders coming up through our system, but how we actually harness that energy amongst the recently retired staff that we've got, for example, who often leave the workplace with unparalleled levels of wisdom and experience, and don't often have an easy way of giving back, and often want to. We'd like to be able to point to new ways of working, which demonstrate an ability to be flexible and agile and respond to challenges as they emerge. And we'd like to be financially sustainable. We'd like to be able to demonstrate that we are partnering with partners beyond the NHS in a way that makes sense to them and it makes sense to us, that it's mutually beneficial for the common good and for all of us in the community. Isabel, next slide, thank you. So just to touch briefly on what we've accomplished since starting down this track in March last year, having built the Dragon's Hospital, operated it, put it on standby and then decommissioned it. In that context and following on from that, we've harnessed that energy to create this learning platform with the King's Fund. So we're working on 2 papers, one on systems leadership, one on innovation, to tell the story of how we've, in the last 3 years, and hopefully anticipating the next 5 to 7 years, implemented our Shaping the Future Wellbeing strategy across the organisation. We've won money to continue to expand what we call the Spread and Scale Academy. Some of you may have participated in it yourselves, working with the Billions Institute in the States, and now through the Intensive Learning Academy with people across Wales, to give them the skills and opportunities to embed their ideas on a much broader scale. We have, if you look down the right-hand column there, you'll see that we've set up something called the Change Hub, which is really an initiative to demonstrate a surge capacity amongst our own organisation and to try and implement ways of working that are both rapid but also incredibly targeted and driven by data analytics too. And an example of this was our vaccine sprint programme. And then we're very excited to anticipate the work that's beginning to emerge with the Cardiff City region, and and the various different innovation challenges that we're participating in there. Next slide, please, as well. Thank you. And looking ahead then, beginning to, in the spirit of this morning and being collaborative but ambitious at the same time, beginning to put some numbers on these things. And so you can hold us accountable to some of what we're setting out to do. And I'm aware of the time here, so I'm going to move on to the next slide as well. Thank you. I'm trying to keep this within time. And we would like very much to be as open as possible and open to each sector, each corner of the system. We would like, for example, to bring you in to help us build this partnership with Johns Hopkins University and the Hillary Institute, each of whom are helping us in a different way. Johns Hopkins have expertise in community organising. Hillary Institute are experts in leadership and have a series of awards which we will be joining them in delivering in Wales. And next slide, thank you as well. So having moved from the Dragon's Heart Institute, Dragon's Heart Hospital through to the Dragon's Heart Institute, this comes, of course, with a new identity and a new modus operandi. And this logo, next slide as well, is a hint really of what's to come. So through a new website, through this virtual reality platform, embedded within Cardiff and Vale, but very much looking outside the health board as well to partners, we hope to be able to create new ways of working, new ways of doing business, new ways of thinking, all within that broader network. So we would be delighted to listen and recognise the huge experience in this environment of collaboration already, and to take our place in that and be guided by you in the most effective way that we can. So thank you very much for listening.
Will, thank you so much. And I think as today and the rest of the week rolls on, I'm going to be sounding a bit like a scratch record. There is so much tremendous innovation and new projects and excitement going on at the moment that it really is. I think it's going to be a really interesting year as a number of these projects develop. Great to see a new identity, a new brand being launched, and more importantly, the activity behind that brand. Love the big tent, you know, as a nation who love their Eisteddfods and their and the Royal Welsh, it feels very Welsh way to get together and to discuss and engage. I think it would also be true to say that your presentation was a really timely reminder that innovation isn't just about products and drugs and devices. It was very much you kept on bringing up topics that were about how people work and how they collaborate and how they work together, and the wicked problems that we'll be facing. So I thought that's really intriguing, and it'll be interesting to see how that develops. So no, thank you very much for that. And sorry, the other thing I would just mention is that isn't it great to see, given the Dragon's Heart Hospital was such an ephemeral project, that it came together, it was planned, it was developed, it served a purpose, and then was decommissioned. Isn't it great to see that there's a legacy and some value that we can take forward in that? So really do appreciate that, and thank you very much for your time and for the time of your assistant there in the background. And great to see the family all involved. So Will, thank you very much. If anyone has any questions for Will, if you'd like to put them in the chat, then that would be great, and we will hopefully keep hold of Will for a few minutes to continue that conversation. In the meantime, you've had the charitable sector, you've had the health boards, and so it wouldn't be a MediWales event if we didn't then have the perspective of industry. So we're calling on the very best to represent our industrial colleagues in this collaborative event, and we have a very much my pleasure to introduce Liam Connell, who is Roche Head of Workflow and IT Solutions. And Liam, you have a presentation on laboratory data analytics solutions from Roche Diagnostics. So the floor is yours, sir.
Yeah, good morning, and it's really a great pleasure for me as well to be here, and you know, also Roche, very happy to support MediWales, and indeed, so far I've been super impressed with everything that's been going on, and I think it's a real demonstration of where we are right now in terms of everything that's happened from a digital aspect, and that's certainly something that Roche are taking very seriously, and that we are absolutely working towards it and on when it comes to aspects of digital solutions. So hopefully you'll be able to see my screen. So I think, William, you mentioned last in your presentation the use of data and being more data driven, and that's absolutely something that we at Roche are taking very seriously as well. And we've had you know, working across the NHS as a whole, across the developed nations and indeed in Wales, we've had feedback from our customers around the fact that, you know, at Roche we are the biggest provider of IVD testing globally, and with that produces a significant amount of data. And indeed, the pandemic has shown that this data and the value of this data is certainly needed in terms of how we operate day to day, but indeed how we react and use the data, be it, you know, to do with the testing numbers, obviously, that you see that the government publish every day, and really we've tried to be innovative in that field when it comes to the use of data analytics. And with this, actually bought Roche acquiring a startup organization based in the US called Vuix, where we had a gap in terms of our product offering, and really looked to fill that gap with a laboratory data analytics solution. So what Vuix is, it's this end-to-end laboratory data analytics solution, which really provides all of the data that's sitting within the instrumentation and the testing that happens within our laboratories across the NHS, and really surfaces this data so that you or the end user can start to use this data to really look at improving both how you operate within the laboratory testing area, but also looking at the impact around diagnostic testing and the outcomes of this. And I think, you know, if you look at the statistics, they say anywhere between 60 to 80% of any clinical decisions are based on diagnostics, laboratory diagnostics tests. And obviously we've seen that exacerbated throughout the pandemic when it comes to all the different types of testing, be it PCR testing for COVID, antibody testing, or indeed, like you see the big push around lateral flow testing right now. So what Vuix is, it's essentially a secure and scalable data analytics platform. So when it's built upon these fundamental building blocks of data security and privacy, so they're really the license to operate when it comes to using data analytics, and especially when looking at healthcare data. So within the data source layer, what we have are multiple data sources, be it our Roche own IT solutions, but actually also the ability to integrate laboratory information systems and electronic medical record data into an integrated platform, which is a cloud-based solution. So the layer and data integration there is the Vuix platform, which is cloud-based. So we can integrate multiple data sources into this platform. And then on top of that, build these applications which can then surface the data depending on your particular type of use case, and also depending exactly what the type of data you want to focus on. I'm going to focus on two applications today. The first being LabOps Core, which in fact we've partnered with a University Health Board in Wales on that, and the other is DX optimization. So these are the two applications and the two data solutions that I'll focus on in terms of surfacing that data that I was talking about. So just to give you some background of what actually Vuix is, so like I said, it's an end-to-end data analytics solution, and really its purpose is to improve testing and operational outcomes within this secure and actionable data. So first of all, we're GDPR compliant. I think, you know, that's certainly, like I said, a license to operate these days. And we use a technology called ETL, which is essentially that we extract the data from its source. We transform the data, strip out the parts of the data that we do not need or certainly not interested in, and we load this data into the cloud. And within that, we have different purpose-built and packaged solutions, depending again on the use cases or the pain points that the end user has when it comes to the laboratory data. We've mentioned collaborations several times throughout the morning so far, and it offers convenient collaboration tools, which allows this sort of let's say, health board exchange of the data. And it's quite an interactive user experience, really easy to use, can access significant amounts of important data within a couple of clicks. So that, like I said, the two applications I'll focus on, first of all, is LabOps Core. So this is really looking around how we best manage core lab operations. We've often talked about, and you've probably heard throughout the media in the last year, around this term called turnaround time. So the amount of time it takes to process a specimen or a test within the lab setting. And then the next application is DX optimization, which is really looking at clinician ordering patterns and looking around how we can start utilizing diagnostic testing and really looking at that right test on the right patient at the right time. So for LabOps Core, you know, although everybody says, okay, well, there's obviously so much testing happening in the lab, and you know, it's obviously an expense to the health systems, but actually about 50 to 70% of all direct clinical laboratory cost stems from laboratory staffing. And what Vuix does is it identifies opportunities for staffing, process, quality improvements, and really looks at to help laboratories reduce waste, increase efficiency, and really drive significant value back to the lab. And three important points of this are around efficiency. So looking around how to measure daily performances. So each test that goes into a laboratory, arrives into a laboratory, be it from primary care, secondary care, has a specific turnaround time. For example, you know, if somebody presents to an A&E with chest pain, they would have a troponin test. We generally try and turn around this in an hour or less, in order then what will happen down that patient pathway. So really trying to manage this efficiency when laboratories are performing hundreds of thousands of tests a day can oftentimes be quite difficult. And really what we need is the data to support that. Also, it's a bit around transparency. So really allowing all laboratories to have full transparency of their data and really look at the service level agreements that they have, be it with their health board or with the wider testing infrastructure. And productivity. So obviously with the demand that's gone up in testing within laboratories over the past 12 months, the labs have really been asked to do more with less. And in order to support that, what Vuix LabOps Core does is it helps end users analyze trends to then help them optimize their staffing and really get more done with less. So it enables this data-driven decision. We've talked about that. I've heard it mentioned a couple of times this morning, and really in the past, I guess labs have been subject to unfortunately having a finger in the air approach to a lot around how they deal with their data. But what Vuix LabOps Core does is that it allows laboratories to streamline their workflows to really focus on turning around those tests in a short space of time. It also helps them optimize their staffing, so really allowed to look at those detailed outlooks of how busy the lab is at various times of the day to make sure that they've got a staff coverage to cover that. And also allows labs to be more proactive and really empower process improvements and look at, you know, optimizing that operational decision making, which is obviously super important when it comes to, you know, the peak and trough demands that are on laboratory services. And we've seen this as a challenge for all labs throughout Wales, certainly over the last 12 months. So just to give you a bit of a look and feel, so it's a Tableau-based tool. So we have lots of interactive dashboards and reports. So it allows us to look at things like instrument utilization. So how much capacity do laboratories have for testing? Allows us to look at trending that. And also looks like things around turnaround time metrics. So really focusing the effort on trying to turn around those tests in the shortest space of time, therefore having the most clinical impact for the patient at the end of the day. The next application that I'm going to talk about is DX optimization. So a slight different approach. So whilst it's still laboratory data, what we're doing now is looking at, okay, well, how can we start merging laboratory testing information with that of the electronic medical record of the patient? So really looking at, okay, well, variations in test ordering can have potential impact on patient delayed test results, can have implications on extended hospital stays, cost of care, and obviously these are all having a significant downstream effect on how the hospital operates as a whole. So two areas of focus with this application, DX optimization, is looking at overutilization of tests. So when there are situations of inappropriate or unnecessary diagnostic testing, to areas where we have underutilization of tests. So analyzing physician ordering patterns and trends to make sure, again, that the right test is done on the right patient at the right time. And just for example, on underutilization, you know, we see that we have new biomarkers that are coming to market and coming to be available for patients, things like NT-proBNP for heart failure, or preeclampsia testing, certainly to help and support with that preeclampsia patient pathway. Oftentimes these can be difficult to gain access to in the early days, both in terms of perhaps testing infrastructure or cost. And really what this application can do is maybe identify overutilization in one area where savings can be made in another area, and then promote perhaps the use of these tests when they're actually clinically needed. So what DX optimization does is it looks to start impacting on testing protocols. So again, it starts to identify opportunities to eliminate testing with no diagnostic value and to minimize testing gaps. A typical example of this is to be looking at, okay, well, can we analyze over the last 6 months every patient that is presented with chest pain to A&E, what tests they've had got carried out, how often the test was done, who carried out the test, etc. And really look at, okay, well, do we need a standardized testing protocol for this particular type of patient? I mean, chest pain is one that there's probably already one in place, but that's not to say that we can't use it for COVID-19, for example, to look at, okay, well, every patient that presents with COVID symptoms, what's that testing protocol that's carried out downstream from that? Also around cost, you know, I think that's there's nothing new there in terms of the cost pressures, and certainly that will probably become even more so a challenge for health boards in the coming 12 months. But we really look at reducing unnecessary diagnostic testing, which can cause delay in patient discharge, and also the additional patient visits, so readmission rates, for example. And then finally, looking at increasing engagement. And I think, you know, again, I've said it several times around how the pandemic has highlighted the value of diagnostics. And I think, you know, if we can drive physician and collaboration across the different areas within the hospital setting and the diagnostics and clinical settings, to really look at how can we can drive testing utilization and make sure that we're doing, again, the right test on the right patient at the right time. So some of the examples for this around physician ordering patterns. So for example, looking at every physician that we have in the hospital, who's ordering what test, when are they ordering it, how often are they ordering it, what patient are they ordering it on? And then also looking at, okay, well, can we look at things like comorbidity combinations? So if we have a patient presenting with you know, abdominal pain, is it something that they've got underlying? Patient presenting chest pain, do they have, you know, a history of type 2 diabetes or for example, COPD? And then what testing protocol do we have to implement based on these comorbidities that potentially exist underlying for that patient? So I'm just going to give you an example of where we partnered in Wales. So we've implemented Vuix Lab Ops Core at Betsy Calwelder in Glenclwyd. This is we have a managed service solution contract with this health board. And really, what we did was to look at, okay, well, there were specific pain points within the laboratory at Glenclwyd when it came to things like turnaround time, but probably the biggest pain point was the time spent by the team and the staff at Glenclwyd in generating this data. So whilst the data was available, it was very much sitting in Excel spreadsheets, and it was very much sitting, you know, where it had to be extracted out, and somebody manually spending the time analyzing this data, because actually for a lot of this data, it's needed from a compliance point of view. It's needed from you know, within the health board to make sure that the labs are meeting their service level agreements. So what we did with Glenclude is that we had some use case identified. So we really worked with the lab teams and the lab personnel around specific use cases that we could support the product with. And then we actually implemented the application. We customized the dashboards based upon the needs of the team at Glenclude, and we trained the users up. And really, what they were able to do is literally in a couple of clicks, and even automate reporting that was probably needed to be done sometimes on a weekly basis, and deliver those reports and dashboards to them in an automated fashion. So really been more agile in their approach, and also eliminated a lot of the manual work that they actually had to do. We had two main use cases now in routine use at Glenclude. One is around workflow management. So this is around analysing those turnaround times, making sure that the turnaround times meet both the Royal College of Pathologists guidelines, which is basically any urgent test, 95% of those to be turned around within 1 hour. But also around sender information. So really looking at, okay, well, how many tests does the lab receive? Where do these tests come from? Are there certain trends within this test? Is it a case that we, need to be more, I guess, proactive rather than reactive in terms of the demand that's coming our way with the testing in that, and allow the team there to be able to have more oversight, and even look at basic things like making sure they had sufficient orders, and making sure that their supply chain was actually correct based upon the demand that was coming through the door. And finally, it really allowed the team to have this continuous improvement. They've been able to progress, look at their tracking and look at progress reports around that, and really look at being able to trend the metrics and be a lot more on top of their data, and really allow them to make sure that they're offering the best service for their patients within their health board. So that was a very a quick overview of our products. And I think if I'm to look at it, we have a number of different products, even products that we've launched since the pandemic. For example, one specific for PCR testing for COVID, and we're really looking at being agile in the approach to producing these data analytics tools, and therefore overall be able to produce what the market needs in a very short space of time. So thank you very much, and on behalf of Roche, we're very, like I said, very happy to be supporting this initiative.
So Liam, thank you very much for that. That was really interesting to have a bit of a delve into not only Roche's work in collaboration with Wales, and that was a great case study to see that, but also to get a new view on Roche. We hear an awful lot about the diagnostics and the pharmaceutical side of Roche, but to see where you are in the digital field is really interesting. We later on in the week, as you probably know from our program, we have a full day devoted to digital and digital transformation. So it would be really great if you're able to join us for that day and join in with that. So thank you very much, Liam. That was really interesting. So now we've had a number of new friends join us for this presentation so far, and it really has been great to meet some new people and to see some really exciting new projects. But now we're going back to talk to somebody who's been a friend of MediWales for a very long time, and so it really is a delight to introduce Carys Thomas as our next speaker. And Carys is from the Welsh Government, Head of Policy R&D Division, Health and Social Care. You must have a huge business card, Carys, and to have that in both Welsh and English. And Carys is speaking on the future of UK clinical research. So Carys, the stage is yours.
Thank you very much. I can assume you can all hear me, so I will just continue.
Yes, we can.
Brilliant. Thank you, Gwyn. Yeah, it's lovely to be here, and thank you for inviting me to speak. So I'm going to obviously continue a little bit more on the theme that Orod and Jazz have picked up this morning, which is around the research agenda. And I caught up with Jazz this week, actually, when she was telling me about the Velindre ambitions. And what I'm going to tell you about now is extremely similar. And what's really great about that is the work that's going on a UK-wide level, national level, and obviously local level is very much aligned at the moment. So what I'm going to do over the next 10 minutes really is just give you an overview of a document that was published actually only last Tuesday, which is called The Future of UK Clinical Research Delivery, Saving and Improving Lives. So this is an UK-wide vision developed over the last few months, and it's got sign-off by the four UK country ministers, which is absolutely really great actually, because it really sort of signals their kind of commitment to the clinical research agenda, and in particular where we now need to focus on restoring the sort of pre-COVID research agenda, and also build on what we have learned over the last year to build a more stronger and more innovative research clinical environment across the UK. And of course, that all links into us supporting the sort of UK-wide commitment to be a leading global hub for life sciences. And obviously, Wales is very keen to play their part. So before I tell you a bit about the vision, I just really wanted to kind of reflect over the last year, about the contribution the NHS has made, particularly in Wales, but it is wider than Wales clearly, which has really sort of obviously inspired the vision. The UK R&D systems response to COVID has really been fantastic. It has been slightly at the cost of research in non-COVID areas, but I will return to that slightly later in my presentation. But we've seen over 36,000 people taking part in COVID research studies in Wales, which is a real significant contribution. So these relate to the vaccine trials that have happened across Wales, of which Orod has played a key part in this morning. And, thanks to all the volunteers, these numbers will continue to rise. I think, Isabel, you're in control of my slides. Thank you, Isabel. So when it comes to the number of studies that's been taking place over the last year, we've had 114 COVID studies that have actually been running over the last year, phenomenal amount. 46 of these were classed as the urgent public health studies. So this was determined by a sort of a UK prioritisation panel. So this is really, really great. And I know most of you will be reading everything that I read in the news, but there have been some real success stories. A real highlight has been the recovery trial. This was the biggest randomised platform clinical trial. It was approved in only 6 days. It was up and running in 3 days. And Cardiff was actually the first site of where the recovery study opened. And this study actually also recruited 38,000 people across 177 hospitals across the UK, and all the 7 health boards in Wales participated in it. And obviously now the recovery study's gone international. Last summer, this particular trial found its first major defence against COVID, dexamethasone, which reduced the death by the sickest patients by a third. And it's tested a number of treatments. Some of them haven't worked, and we have to learn from them as well. And that's really important. And obviously it continues to evolve. So the point I really wanted to make at this point is the trial format, which is the platform study, where there are lots of different therapeutic arms coming in and out of the study and randomized and given to different people, is very easy to understand. It's very easy, and it can adapt very quickly to test new therapeutics. And we are very likely to see the shape of these types of designs in research going forward. Next slide, Isabel. So as many of you have been doing, we've been spending a lot of time over the last year looking at what worked well, what lessons did we learn, and what do we keep that we've developed that we can build on moving forward. So working with a range of partners, as you can see on the screen, we've established a sort of a coherent UK-wide vision where I can actually say there's been enormous buy-in and engagement. During the last year, there's been a high level of sort of mutual trust and respect that's developed across a range of organisations, because we've really had to kind of explore and address the challenges, at extreme pace, in a very sort of highly uncertain context. So knowing that the impact of the pandemic on research has the potential to have a sort of a long-term and a far-reaching influence on the future of clinical research delivery, in Wales and across the UK, and probably further beyond that as well, the health departments in the devolved nations and the Department of Health and Social Care, along with the Office for Life Sciences, have been working really, really closely together to develop a programme of work which we've referred to as the Recovery, Resilience and Growth of UK Clinical Research Delivery. And, the primary focus of the vision is about restoring the activity that was underway pre-COVID, but really looking for opportunities to expand the clinical research across the UK moving forward. So I'm now going to just share with you some of the key themes within the document. So next slide, please, Isabel. So there are 5 key priorities or key themes that are coming forward. So first of all, the first one is very much about supporting sort of patient-centered investigations. This is very much aligned to what Jazz was talking about a little bit earlier. It's about ensuring that participation in research is a patient's right, and it should be absolutely as easy as possible. It sort of means, designing studies. That means that there are less hospital visits or GP visits, and much better use of sort of virtual delivery models. We've seen some of this come through over the last year, so we know we can do it. And I think this is what we're hearing that makes it easier for people to participate in research. The second theme is about delivering faster, more efficient and more innovative trials. Obviously, this is a very important theme because it's about making sure the UK remains internationally competitive in terms of winning sort of business in order to run trials for the benefit of patients in the UK. And what we really want to achieve is that the UK patients are some of the first in the world to get access to these new treatments. Again, something Jazz mentioned this morning was about creating a sort of a research positive culture, through about embedding research in the NHS. It's really important that all health and care staff view research and trials as a key part of sort of patient care and then prioritise it accordingly. And then fourth, creating that sustainable and supported workforce is absolutely key moving forward. We want to be able to offer sort of rewarding research opportunities and careers for all healthcare and research staff, across all professional backgrounds and across all research. And a key theme that's coming through this morning as well is making sure that we have digital and data infrastructure in place so that we can really escalate our ability to deliver faster trials in terms of setup, in terms of recruitment, and then in terms of delivery as well. So a key theme, the 5 key themes there coming through. So on the next slide, I just wanted to kind of mention where we're at next with the programme of work. So as the 4 UK countries clearly committed to working together, and we're now moving into the implementation phase. And the commitment is that we will be publishing action plans early in the summer months. So across the 5 sort of priority themes I just talked about, there are sort of 7 actions which are on this slide, which will have sort of specific interventions and initiatives that will fall beneath them. And this is what's been currently sort of developed at pace. Now, most of these sort of 7 actions read across, as you probably noticed, to the priority themes that I've just touched on. So I won't repeat myself. But what I will do is I am going to pull out one of the actions, which is on the left, which is about aligning our research programmes and processes with the needs of the UK health and care systems. And what this really will mean is that we will result in developing some new mechanisms to fast-track high priority research. And this is obviously a new strategy that we're taking ahead across the UK, where we are actually, in order to help us to kind of recover our portfolio that we've lost over the last year, we do realise that we have to now prioritise what we're going to put our resources into. So one of the first interventions that we will see happening as part of the recovery plan will be the prioritisation of commercial research. And this has been chosen primarily, not only because obviously the life sciences agenda is really important, it's really important that we do maintain and increase our business with global companies, but also, we do need to mitigate the impact that the loss of commercial income the NHS has seen over the last year has been quite critical, in terms of creating a sort of stable infrastructure. So the 4 ministers, the 4 policy departments have agreed that we will take forward the prioritisation of commercial research. But having said that, we will be keeping a very close eye, obviously, on the non-commercial research agenda. Because working obviously with our charitable partners, our academic partners is absolutely key as well. And it doesn't mean that actually we're going to be prioritising commercial research forever. It just means we're going to be prioritising it now and then moving forward, looking to see where the demands and the needs are in the health and care systems. So as we move to the next slide, I just thought I'd finish off by just giving you a bit of a flavour of some of the new initiatives that are coming our way. So in terms of improving the speed and efficiency of study setup, what the COVID response has done is it's really demonstrated what is absolutely possible. We've seen really rapid approval processes, including ethical and speedy NHS setup and recruitment into COVID trials, but with no loss of rigour and decline in research standards. So this actually signals that we are able to do things as we've done them before, but much better, much faster, much more efficiently. So we are currently working with our UK-wide partners to develop a fast-track pilot of commercial research. And this will obviously include some of the wicked problems we do have in the system, which is around contracts and costings. And there are discussions underway at the moment with global pharma around selecting a number of high priority studies that we will take forward across the UK. And what we'll be doing is we will be testing, some of the UK coordination processes that have been developed over the last year and putting them through sort of a test in the non-COVID context. And we'll hopefully see that then informing future operational processes. So the Health Research Authority has a new service that's offering 50% faster research ethics committee review for non-COVID clinical trials in the UK. And that is happening now, and it is set to continue. And that has had a lot of positive feedback, particularly from pharmaceutical companies and commercial contract research companies. That is built on a sort of a 3-month pilot that happened relatively recently. It uses a sort of an expert research ethics committee. And what the intention will be with this is that we will keep rolling this out, testing it, evaluating it, and hopefully then we will be able to incorporate it into sort of the wider sort of rapid approvals and study setup processes that are in train and will be coming as part of longer term improvement programs. And this will obviously include the integration with the combined review with the MHRA, which offers a sort of a single application, combined review and a decision on a clinical trial. So lots of good stuff coming really to help the researcher community, to help the sponsors to get their studies through systems quickly and being able to set up very quickly for obviously patient benefit purposes. So in Wales, we're certainly not going to let the grass grow either. We've seen that actually some of the processes we've put in place over the last year has had a major impact in how we coordinate our oversight of the Wales clinical research. And what we have found is by working a lot more collaboratively, so I'm talking here about the academic sector and the NHS as well, that we are able to speed up the way we are working and ensure that every organisation that has the capability to set up studies are able to do so. So this means that actually that we're able to really sort of have sort of geographical breadth when we're actually opening up studies in Wales. So we will kind of formalise something that we've already set up, which is a Wales-wide coordinated study support service. And through this, obviously, we'll create this sort of national oversight. but we really should be able to see, an increased service, improved on increased service to sponsors and researchers, which should involve sort of multiple conversations happening. And obviously what we're really keen to do is to make sure that, there is a Wales-wide system for sort of troubleshooting when things don't quite go to plan. And something obviously Jazz mentioned this morning, and something that's very close to my heart, is we really do need to support our workforce. We need to create the time for people in the NHS, not necessarily just the researchers, but other people that are part of the research pathways, to have time to do research and make research a core function alongside service delivery. This will be a key project that Health and Care Research Wales will be working with the NHS on, and we will be taking this forward over the next year, because I think there are a number of sticky issues in order to help people realise that they can create some time to do research, and we need to work with the NHS leaders to enable people to have that time so that they can participate in some of the great research that's going to be happening in the future. So moving to the next slide, I just wanted to finish and share with you one final point, which is really about the recovery of the non-COVID research agenda. Now, all the NHS organisations, back in March last year, were almost told overnight to pause all non-COVID studies. But what is absolutely amazing is we are now seeing 2/3 of the NHS research now back up and running in Wales. So these are the 450 studies noted on the slide. And I have to tell you, this is no mean feat. It's a real credit to the organisations and the departments with them and the staff within them, and obviously to the NHS infrastructure, that's been built up obviously through Health and Care Research Wales, that's really been able to create this sort of platform to get the infrastructure in place and the support systems in place, and we will continue on the recovery. This has to be back to 100%, and it has to be better again. And we need to start the new research that people want to start, and we will do that in light of the developments highlighted in the vision document as well. So on my final slide, I have just put the link down to the vision document itself for those of you who want to read it. It's on the Health and Care Research Wales website. It's on the uk.gov website. If you search clinical research delivery vision in the Google, you should be able to get it. But I'll also try and send the link round on a tweet later today. Thank you, everyone.
Thank you very much, Caris, and we will share that link in the chat if that's if you'd like us to do that as well, to make sure that everybody attending today has an opportunity to click it and take a look. Caris, thank you so much. Great news to hear about the pace of recovery. And both the recovery and the new plans. I think I having known you and the organisation for quite a while now, I know that you had quite a firm foundation of infrastructure and workforce to build both resilience during the COVID pandemic and an ability to pivot and as you say, an ability to recover. So none of that is a surprise to me, but it's very good to hear. So thank you very much for that, and we will particularly be keen to work with you and support your activity on the efforts to build your commercial research portfolio. As it'll be no surprise to you, Caris, to hear me say that I particularly like to support the engagement with Welsh companies and the companies in medical devices and diagnostics, as well as your tremendous portfolio in working with pharmaceuticals, because that obviously gives us that double benefit of economic impact as well as clinical benefits. So really great to hear that presentation, and thank you so much. And Caris, I assume you or the team will be joining us for the living research session this afternoon, because that's our focus section on research activity in Wales, and that starts at 1:30 this afternoon. So do hope to see you or the team later today, Caris. So thank you very much. Right, our final presentation, and again, an old friend of MediWales, so it's great to hear hear from our old friends and colleagues, and also an organisation that's already been mentioned in Andrew Goodall's presentation earlier today. It's my pleasure to welcome Nigel Rees and Ed Harry from the Welsh Ambulance Service, and to hear a little bit about AI cardiac arrest detection. So is it Nigel or Ed who's starting off? I'll hand over to you guys. So far, we don't have anybody.
Can you hear me now, Gwyn?
Perfect, Nigel.
Brilliant.
Thank you. The floor is yours.
Okay, thanks. Yeah. Okay, so it's great to be here. MediWales has been a great friend of the Welsh Ambulance Service in our research and innovation journey, and it's going to be presenting today on this project, Assist, Assuring Safe Artificial Intelligence in Ambulance Service 999 Triage. My name is Nigel Rees. I'm the Head of Research and Innovation for the Welsh Ambulance Service, and also Health and Care Research Wales Trauma and Emergencies Co-Specialty Lead. My colleague Ed Harry is here. Do you want to introduce yourself, Ed?
Hi, good morning. My name is Ed, and I'm an advanced paramedic practitioner working for the Welsh Ambulance Service, and I'm also project support for the Assist project.
Okay, thanks, Ed. Ed's also one of our RCBC Wales fellows, PhD fellows, which just want to kind of give him a shout out for that we're really pleased that he's taken that on. So we're going to present Assist today. Ambulance services across the world have been turned into technologies, have always turned to technology to improve the efficiency and effectiveness of the care that we provide. And in recent years, they've turned to artificial intelligence and to exploit the benefits. And we're presenting today this project on cardiac arrest detection in our ambulance clinical contact centres. I can hand over to Ed just to give you a bit of a background or context to the clinical problem we were facing.
Okay, thanks, Nigel. So traditionally, when people, the public, think of ambulance clinicians and paramedics, the ambulance service, they traditionally see the cardiac arrest scenario, the CPR. Unfortunately, the out-of-hospital cardiac arrest issue is currently around 8.6% survival, which is nowhere near as high as the other performing countries, which have rates of over 20%. And the early detection for cardiac arrests and early defibrillation is key. And here we have the chain of survival, which right at the bottom identifies the early defibrillation. And as you can see, the access to community defibrillators is becoming more and more widespread. But we have the opportunity now to really intervene right at the beginning with the Assist project and the use of artificial intelligence. So I'm just going to hand back over to Nigel to explain the project.
Okay, thanks, Ed. So as I mentioned, we're looking at ambulance services internationally, looking to digital, and WAST especially has really put a focus on the use of IT and digitization in our care services. Ed mentioned some of the figures around cardiac arrest and survival. Despite lots of efforts, survival hasn't improved massively in the UK for the last 30 years. And for every minute of delay of a defibrillator being applied to somebody in cardiac arrest reduces chances of survival by about 10%. So early recognition is paramount. And one such project that we're involved in is the use of artificial intelligence through a module developed by a company in Scandinavia called Corti, and it's I'm just going to show you a quick video clip. Some may find this a little bit upsetting. It's from Seattle. This is a call recording using artificial intelligence, and let's just play the clip.
Fire and Medic 1, the address of the problem?
1818 Bigelow
Avenue North.
Okay, in 1818 Bigwell Avenue North, apartment 202.
Yep.
What's going on there?
My dad's either having a heart attack or a stroke or cardiac arrest. I'm not sure.
What's going on? Is he conscious and awake?
No, I mean he's breathing, I think, but he's on the floor. And
okay, I want you to go look at him and see for sure if he's breathing. Okay, and I'll stay on the phone with you.
He's breathing. My husband.
Okay.
Says he's breathing, but he's laboring.
Is labored breathing? Is he responding to you at all?
No.
Okay. Does he have a history of cardiac problems?
No.
Okay. I got some help coming. Hang on the phone with me here. So if before the firefighters get there, if he stops breathing or it gets really slow, I want you to call me back and we're going to start chest compression CPR. Okay?
Okay.
Just keep an eye on him. Okay.
Okay.
And I want you to look at it one more time before I get off the phone here. He is breathing normally for sure. Is that correct?
I mean, there's blood coming from his mouth. He's bit his lip or his tongue.
Is that him in the background?
Yes, yes.
Okay. So, like I said, call us back if anything changes. They should be there in just a few minutes, okay?
On the right-hand side of the screen, was showing the AI listening in. It's listening to the breathing patterns and what's going on in the background, and making sort of assessment of the words that are being used and using its processing power, and over 20,000 previous cardiac arrests to work out whether this could be a cardiac arrest. And so studies have been completed on this package and found that there were 43% fewer errors using the program, and a 92% diagnostic accuracy in using this in the clinical contact centres. So we explored the use of this within the Welsh Ambulance Service, and lots of questions remain around AI, around governance, human factors, how it interact in our clinical contact centre. And we set up a research development group with York University, Critical Systems Group, and a range of academic partners. And we were successful in securing funding from the Assuring Autonomy International Programme to deliver a project we called ASSIST, Assuring Safe Artificial Intelligence in Ambulance Service 999 Triage. And it encompasses 3 work packages. The first work package is Embedding the Real World, where we're engaging with stakeholders across the ambulance services in Wales, working with regulators and clinicians to present the real world application of AI, not just in cardiac arrest detection. We're exploring, and I've submitted proposals and bids in stroke detection. We're working with Public Health Wales on syndromic surveillance on respiratory and emerging diseases. And we're exploring areas such as mental health and well-being surveillance of staff. Second work package is a qualitative study and exploring what are the safety assurance requirements of ambulance services. And the third work package is led by the University of York's Critical Systems Group, which is building a self-contained safety assurance case, which covers both safety assurance, making the safest service safer, but also building up a body of knowledge in this area, which is pretty sparse at the minute. So in the project, as I say, we'll be contributing the body of knowledge and increase our understanding of the interaction of AI in terms of out-of-hospital cardiac arrest detection in our clinical contact centre. Long-term goals are to develop future randomised control trials around this and other areas, as I've mentioned, and develop this technology further. And I'll hand over back to Ed just to sort of explore some of the possibilities of AI from a clinical perspective.
Thank you, Nigel. So the potential for artificial intelligence for AI in the ambulance service is really, really endless. From a clinician perspective, any advancement in the use of technology to assist decision making and improving patient outcomes would be wholly beneficial, and the AI project, the ASSIST project, is really a start of that. In thoughts when we're on the back of an ambulance. As I mentioned, the potentials are endless. Just to think that you could possibly ask the ambulance to pre-alert to the nearest ED the information that's already been placed onto your defibrillator. The potential of using drones to deliver defibrillators, or even assisting decision making. As I said, who knows where we may be in 10 years' time. The potentials are endless.
Thanks, Ed. So thanks again, MediWales. We're keen to talk to people across Wales, policy developers, regulators, and people involved in kind of the safety assurance of AI, not just in this project, but as we progress through this journey. And that's it. Thank you.
Thank you very much, Nigel and Ed, for a very brief but a little window into another exciting new application of technology, and it really was great to see how the use of digital, use of AI can support the emergency services. You are working in an environment where things happen very quickly and decisions have to be made very quickly. And your example there, your presentation really did demonstrate how AI could support that. So I really do appreciate that. We'll be sharing this recording after the event, and so I know a couple of people had some audio issues with that demonstration. So maybe if we can work with you, Nigel, to tweak the presentation so that the one that goes out will be we'll get the full benefit of it. But that'll be great. Okay, thanks. So thank you very much, Nigel. Thank you very much, Ed. So Izzy, if we could just go back to. There we go. So thank you so much, everybody, for being part of today. What an incredible plenary session. From starting with vaccine trials, we've had patient empowerment, we've had new data, new uses of data, digital transformation, new hospitals, new virtual tents. We've had interactive walls. We've had, incredible intent for how the next year is going to develop in terms of new projects, new research, new trials, new collaborations. That I think the whole morning has been one that should be motivating and exciting everybody. So so I really am very grateful to the speakers. Very grateful to Izzy and for driving the technology in the background there, and thank you to Debbie for pulling together our speaker program, and Katie, who will have been working in social media for us today. So thank you to the whole team for bringing this together. We now take a break. We are back at 1:30 for our living research, a session that showcases some of the exciting research projects taking place across Wales. And I can already see some of the speakers there, starting with Keir Lewis, our presenters, who are never fail to provide interesting and enthralling presentations. So I really look forward to seeing you in that presentation. In the meantime, can I just point you towards your Meeting Mojo profile that you will have had a login sent from Isabel. If you don't know where your login is, if you've lost it in a stream of emails, please just tell us. But Meeting Mojo is the platform we're using for partnering throughout the week, and so essentially you'll be able to go in there, put your profile in, you'll be able to look at other people's profiles, and you'll be able to request and schedule an online one-to-one meeting with anybody else who is attending this week's event. So a real opportunity to interact, partner, and to develop projects and find out more about projects that you're hearing about in the presentations. So on that note, I'm 4 minutes late, so I won't hold you up any further. Enjoy your lunch, and I look forward to seeing you at 1:30 this afternoon. So thank you very much.